Welcome back to the True Sports Physical Therapy Podcast. Thrilled to have Dr. Willey with us. Welcome, Q. That's what I'm going to call you moving forward.
Yep.
Just give me a quick synopsis of who you are and why I've been dying to talk to you.
Yeah, so name's Q. Everybody just calls me that. If you call me something else, you probably don't know me very well. I am a physical therapist and strength coach at the University of North Carolina, working only with football here. I do some private consultations with other athletes and across other sports here, and even coaches. And I also work for Barbell Medicine as part of their pain and injury rehabilitation team, and do remote consults all over the U.S., but really all over the world. We're open to that. And I've been doing my own rehab remotely for several years now. And I used to own my own physical therapy clinic in Durham, North Carolina, prior to stepping on to the UNC football team. So I've kind of had some experience in both the private as well as now back in the university setting. I was a university athlete and at University of North Carolina. And so going back to my alma mater was kind of a dream come true, and an opportunity I didn't want to pass on, and working with some great people there. My coworkers are fantastic, as well as working with athletes that I'm very connected to and have a deep, interest in as a former Tar Heel.
Yeah, no, I love it. And as a former Terp, I used to have issues with Chapel Hill, but it's really crazy. Like, as I've been treating high-level athletes, the UNC kids I treat, I absolutely adore. It gives me an awesome perspective of what goes on in Chapel Hill. So I have no doubt that it was great for you to kind of get back there. Also, you didn't mention that you played lacrosse. A guy from Baltimore, that's a big freaking deal, Q. You should lead with that.
Yeah, it's true. If you're a Terps fan and from Baltimore area, lacrosse is massive.
Yes.
But where I'm from, I'm originally from Salt Lake City, Utah, and lacrosse is not king there. So
not yet.
Not yet, exactly. So, but yeah, I did. I played lacrosse at University of North Carolina as well. And so, yeah, awesome to be back.
Well, I love it. Also, you should have a soft spot for my buddy Marcus Holman, who took lacrosse out to Salt Lake, right? From UNC.
100%, except he went to a previous rival school of mine, University of Utah, that was usually historically very terrible at lacrosse. When we were playing them, it would be like, 21 goals to 0 or something like that. And now University of Utah has taken over a little bit more in the West. And yes, Marcus Holman is an absolute animal. Appreciate him. And his father was a defensive coach when I was there. So yeah, they're great people.
Awesome. They are great people. Okay. Small world. So dude, just from your intro, I would love to talk to you about why you left private practice and how you live in both worlds now. But we're going to save that to the end, because you put up outstanding content on Instagram in terms of how you approach the athlete, how you blend these worlds of strength and conditioning and sports rehab. And that's what great sports PTs do. That's why I was super excited to get to talk to you. I want to dive into very specifically hamstring strains and tears and how you look at them and how you eventually get them back on the field. So if you could give me an overarching view of your approach to hamstring tears, how you grade them, and then how you walk them back onto the field.
Yeah. So hamstring tears across team sport athletes is probably one of the more common injuries. And I feel like, especially in football, it's one of those things that is talked about so frequently in the circles, in coming from postseason into the off season, as well as the preseason preparation and going into training camp. The number of hamstring injuries is just always one of those conversations that's in the mix. And you see this across NFL as well as the NCAA. It's so common that there has been so much interest in this from both rehabilitation. It's kind of bled into the academic circles, and interest in injury prevention as well as how to rehab. And when you ask about the process of grading, this is where things do get a little sticky. We typically, and I was the same in school, and I'm sure everyone else that may be listening who has been to physical therapy school, or even in your undergrad when you're learning like maybe some basic athletic training type things, or you're coming into any type of injury realm when it comes to learning about the hamstring, there's always the 3 grades. You have grade 1, grade 2, and grade 3. And grade 1 is kind of like the small little interruptions, maybe no bruising, just kind of some soreness that prevents, full function, and it's a little tight back there. And then you're expecting a little bit faster return to play. Grade 2 is sometimes maybe characterized as now there is a little bit more bruising. This is typically something that is seen as a little bit more serious. It's more disabling, if you will. And then a grade 3 is kind of this like catastrophic idea of this full rupture, and a lot of bruising, a lot of trauma. And those are kind of how it's seen. And I think that's an okay way of looking at it. But unfortunately, when we look at the predictive models for any type of prognostic or clinical tests when it comes to hamstring gradation, there's really a very wide variety in what comes out of that. And very little has been found from a clinical perspective, even MRI findings, on how quickly someone will actually return to play, and then what is their risk of re-injury. We know that a previous injury is probably one of the greatest predictors of being at a higher risk for re-injury. If just having a previous injury will put you in that like greater risk category. We know that, but we don't know how much that risk is based on the clinical tests that we have. And what's funny is like when we look at studies that examine how does MRI findings compare to just patient perception of how well that they feel and how quickly they feel they will return, there's no difference in MRI finding versus how good the patient says they feel in return to sport, and the level at which they return to sport, and the level at which they abstain from a future injury. So all I mean to say is that it's not that any of this is meaningless. It's just that these are really complex issues. When it comes to musculoskeletal pain and injury, we've been finding things similar to like low back pain, where it's like, man, we really have to take a much deeper dive into what is pain, what is apprehension, what is fear. There's the major like motor learning components that are happening when someone goes through an injury. Cultural differences, familial differences, social cultural interests. Even if you have a family member or teammates who freak out when you have a hamstring thing, or you've had friends or family who have had major limiting disabilities or loss of careers or loss of season because of hamstring injury, and now you have a hamstring injury, that psychological component will play a factor in how fast you're able to recover and the degree to which you're willing to push yourself, because there's a higher amount of fear and apprehension. So when you ask about how do I grade these things?
Yep.
Boy, we know that what's funny, and in all the clinical testing studies that we have to date, there is a fairly high amount of bias that goes into that. But one of the most likely tests to change your pre and post test probability of a hamstring strain is the taking off the shoe test, where you're just putting the heel of your injured leg on the instep arch of your uninjured leg and trying to like peel the heel of your shoe off. That probably has one of the highest clinical markers related to MRI findings, as well as just overall ability to predict if somebody actually does have a hamstring strain. So I think the study by Michael Raymond, I can pull it up here, but one of the things that he talks about and his group talked about in the study that they proposed was that, hey, guys, we don't have great diagnostic accuracy in this. So really, it comes down to let's rule out what it's not. Let's make sure it's not neural. Let's make sure this is not a nerve-related injury, that this is not coming from the spine. Let's make sure this is not like a femoral head stress fracture of some kind. Let's make sure it's not these other potential, like a DVT in some patients, maybe a clinical kind of indicator of something you should be checking for. But once you've ruled out those things and there's a posterior thigh injury that kind of pops up in something similar that you would expect for a hamstring injury, it's probably a hamstring injury.
Yep.
But the severity or how long that hamstring injury will last, the range of what we have, even in like something that may be a grade 1, ranges all the way from like 5 or 6 weeks up to like 20 plus weeks. I mean, the variation is huge across what we have. So when you're asking like, how do I grade it? Oh boy, it really is from day to day, from day 1 through day 2, 3, 4, and 5 and 6, as we just start early exposure back into some of the things which we'll get into. That's going to tell me a lot more of about how long this athlete will take to return to sport than any like clinical test that I could do on a table, or even MRI finding will tell me. So hopefully that, I know it's a long-winded, but
no, but I think that gives great context to the conversation we're about to have. But it begs the question, why do we grade them?
Yeah. I think we grade them to give people as well as ourselves answers. Think about every sport coach
But
under
it
the
doesn't give
sun,
us answers.
right? But everybody wants them.
Yeah.
And I think it's the same cultural issue that we deal with across other musculoskeletal injuries where people want an image and they want an answer of, how many PTs, every PT out there who's listening to this will have, most of their patients will ask this question of how long is this going to take?
Sure. Sure.
That's the golden question. When can I expect to be back? And the unfortunate truth is that there is very little information or data to suggest that we can give a very reliable answer. Even after I've been working with an athlete for maybe a week or two, I may give them a range of time. But what I'm trying to help them understand is that in the rehabilitative process, it's not so much about getting back to this ideal version of self that they have envisioned. It's about making progress. It's about how can I improve myself today from where I was yesterday? Now that sounds kind of like, eccentric and kind of nice and very zen. And
Yep.
it's cool to tell patients that, but it's not very cool to communicate with a sport coach who needs to know what game can I expect them by. So we have these grading processes, I think, and I think of it more of less like categorical and more of like a sliding scale. Like grade 1 through 3 can obviously just be a total spectrum, and you're just sliding that needle across a wave versus like being placed uniquely, squarely in a specific category with a very specific time. But I do think it gives you some capabilities of a potential time frame that you're looking at. So
You just said it doesn't.
Yeah, and that's the thing. It's like I'm trying to understand, if I grade someone, I have a general idea. I can at least, maybe, if somebody has to have an answer and a sport coach needs an answer, I can give them a range. However, here's the big however,
Yeah.
is I would much rather give a sport coach, hey, here's about the time. However, I want them to be able to do X, Y, and Z. I want objective criteria that, and I can tell the coach by measuring certain things or testing certain things. I can say, hey, coach, listen, we're 2 weeks deep into this thing. I know this is what the athlete was able to do today. This is a Wednesday, right? He did this, 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 and this. I have this specific volumes. I have a specific test outcome measures. He needs to be here. And I give him the idea of where we're going. Now, you can, if it's been 2 weeks and he's made this amount of progress, we already know that about 70 to 80% of the way there is going to come a little quicker than that final 10 to 20%. It gets harder and harder because you have exponential diminishing returns on what you're going to get out of rehab and training. So that said, if we know that he's made this amount of progress in 2 weeks, here's maybe kind of an idea of the trajectory of where this is going, but he needs to hit these numbers or he needs to hit these clinical measures before I'm willing to say, hey, this guy's got a full green light to return to some OTAs, indies, that kind of thing. And I think that goes over a lot better versus a time-based. And most research is actually leaning that way. We see this for ACL. We see this for high ankle type stuff. It's like there are clinical predictors of criteria-based progressions versus, oh, well, it's been 9 months since your ACL surgery. You should be good to go, because we know that that does not work all that often. And the quality of return to play can be variable depending on just time alone.
Yeah, listen, I think you make a lot of great points there. I think what I took away was the education piece, not just to the athlete, but to the coach in your situation. In my situation, I work in private practice. That education, it should be the same education, but it's to the parent, it's to the athlete. Here's where you need to be. And I think it totally changes the dynamic from the crap we got in school, which was what you previously said, which is, hey, it's a grade 2, it's going to take this amount of weeks. Whereas if you're putting in functional thresholds they need to get to, you're putting in objective thresholds they need to be able to do, you have to be able to explain that in day one. Here's where you are, here's where we need to go. Let's see how long it takes. Hey, you've made this amount of progress, we're this amount there. I think there's a lot of great insight there. So I appreciate that. Talk to me about prevention, for lack of a better term. I give you a 90-man roster of football players. What tests are you putting them through or what assessments, I guess, are you putting them through to predict this guy's going to pull a hammy?
Yeah. And that's another really great question. I think it's one that strength coaches and performance coaches and sport coaches all over the country would love to have an absolute, like, definitive answer on. I can't tell you a definitive answer, but I can tell you to date what some of the evidence says and what we have available to us based on the best research.
That's all I'm asking.
Yeah. So to date, like hamstring flexibility, let's start there, because that's one that I hear talked about in the circles of, oh, you're tight. You can't bend over. Well, we have a lot of conflicting evidence in that category. When we measure things like rugby players and Australian rules football players in the preseason, and doing things like, even if they had a previous injury with hamstring injury and they did like a sit and reach test, if most people are familiar with that, you're just sitting on your bum and there's a box placed on the soles of your feet and you're essentially reaching your hands forward down that box to measure how far your fingertips go beyond your toes, things like that. And that's just a general measure of your posterior chain extensibility, let's say, right? And what we found is that those who had better tests on the flexibility of and the extensibility of the posterior chain were more likely to tear a hamstring based on the upcoming seasons. Now, I don't think that, I think some of that could just be, incidental findings. So I'm not saying that hamstring injury is now, the inverse related to, oh, well, if you're too flexible, now you're going to hurt yourself. Yep. But it does call into question how much hamstring flexibility really matters when we talk about the incident of hamstring injury. So I don't think that we can say with confidence that hamstring flexibility is a good predictor. Now, there's going to be some people, sure, if you're doing things like you look at Carl Askling's protocols in both the Swedish Premier Soccer League players as well as Swedish sprinters, great studies where they rehabilitated sprinters and soccer players with more lengthening type exercises. And even like that's been kind of now, I think, adopted into some of the prevention type protocols. And we do it at UNC as well. I think there could be some value there. And I don't know if it's specific to improving flexibility so much as it is just exposing the athlete to ranges of motion that are challenging, similar to everything else we do in training to make someone more robust. So, I don't think that there's anything magical about improving flexibility, but I do think exposing and challenging those things can be very helpful.
Well, sorry to cut you off, Q, but I think in the Askling protocol, they do a lot of lengthening, but under tension, right?
Yeah.
And so I just don't want to confuse that with let's stretch the hell out of your hamstrings and supine and see if it prevents injury. I think it makes so much more sense if it does indeed decrease injury. That would be my question to you. Does the Askling protocol decrease occurrence of hamstring tears? I think he would say yes.
I think Carl Askling would say yes.
Would say yes. Okay, fine. But it's not him just supine mo belt around your foot and stretching your hamstrings for 3 hours.
Correct. Yeah, correct. I think you bring up a very important point there, is that this is still training. It is challenging a range of motion under some duress, under some load. And, that is typically where we see in like high speed sprinting, it's that final extension in that swing leg, terminal, extension meeting the ground. So we're trying to train the hamstring under load in a range of motion that is potentially provocative or putting some level of risk, to the hamstring. We're exposing it at a graded level before the thing versus just stretching for long periods of time aimlessly. And I think that where stretching maybe gets a bad rap is if you think about what's happening at the tendon as well as the muscle, it's simply a spectrum. I can put tension through a tissue in a lot of different ways. I can either have the muscle actively pull against something, or I could just passively go into it. It's still tension. It's just that stretching falls at such a low level grade of exposure of tension that I don't think it's enough to really cause significant remodeling. And I think in that sense, it's more of like a proprioceptive, more of just kind of a general feel of I can change the sensitivity to going to this range, but at some level or time, you do have to train it at that range if you want it to be, robust and resilient to enduring forces at that range. It's got to be exposed to something that is closer to the tension. We know, I think David Opar and Christian Thorberg and Jack Hickey have done a lot of research in the hamstring, and they have a very large kind of protocol list of papers that they've put together of all things hamstring. And in that, they talk about like the hamstring at high velocities of speed can go through somewhere between 5 and 7 times body weight worth of load in that meeting of the ground, very similar to what we talk about in the Achilles. It seems that the whole posterior chain is going to be going through a large amount of violent duress at very high velocities. If that's true, I would not expect a simple hamstring stretch, even if I did it 3, 4, 5, 6 times a week for a minute and a half, 2 minutes at a time, to yield a result that's going to prepare me for a 5 to 7 times load, if that kind of gets at the heart of what you were saying.
Yeah, no, I think that makes a lot of sense. Okay, so you mentioned UNC uses some of the Ask-Link protocol. Okay. You mentioned that the sit and reach test showed an inverse relationship to hamstring health. I think I said that right? Like the better your sit and reach is, the more likely you are to damage your hamstring, potentially. And so taking like those two theories, give me more of what would be a predictor for you in who's going to pull their hammy. The word Nordboard has to come out of your mouth soon.
Yeah, exactly. So we only covered flexibility so far. And I will say too, that there are just as many studies who show that, flexibility either had, no bearing or a potential positive bearing on hamstring injury. And so I think we just get into this world of like, look, no matter how many times we look at it, it doesn't seem like we can confidently say in one direction or the other that this is clinically important. And that's where I just think like, be cautious. If you're telling that narrative or you hear that narrative, or an athlete is like, oh, I've heard flexibility of my hamstring, I need to get my hamstring more flexible, you may want to challenge that a little bit, just because I don't think we have the data or the proof there to say that. Now, yes, let's get into the Nordboard. So when we talk about both force production as well as eccentric force production, as well as asymmetry in the hamstring, these things may be predictive. And when we talk about the asymmetry, there has been 1 or 2 studies that do have some predictive value in the likelihood of going on to have a hamstring injury if there is significant asymmetry. And I could probably pull the numbers of that. The paper that I would cite for this is Hamstring Strain Injuries by David Opar et al. And this was published in, let's see here if I can find the date. I'm not sure why I can't find the date off the top of my head, but they talk about, it looks like 2013, 2012. Okay. 2012, I think, is when this was published. It may have been revised in 2013, but they talk about how asymmetry in something like a Nordboard test or maximal a hamstring strength testing with something like an isokinetic dynamometer, both in like a seated position as well as a prone position in dynamic knee flexion. Those things could be potentially indicative. And there again, I'm going to say that with a grain of salt. They could be, because there was also a paper published, I think in 2023, that talked about extensively the asymmetries in sport and how so many asymmetries are so natural and may even be part of what makes the athlete good in their sport, depending on which sport we're talking about. If you're talking about a very unilateral type sport like soccer, throwers, lacrosse players, or you go back to that, baseball players, some of those things may actually be adaptive, and asymmetry is going to be perfectly normal and natural in those athletes. When we're talking about maybe someone that is a little bit more bilateral athlete who has to go both direction and has high variance, sure, could there be? Potentially, but we just don't have a high degree of confidence or data to suggest that it is super important. But I do think, we'll take measures of the Nordboard at the beginning of each phase of training, and basically players that fall outside of the second standard deviation will definitely have extra hamstring work included in their program. And that's to try to clean up and maybe, take care of some of those potential things, because if it could be a risk and it's not going to take away too much from the training program, it's not going to, really be at any kind of decrement, we might as well hammer on that if we can, because we see it. And if we can make improvements in that, we're just trying to do all we can to, basically stave off some of these injuries. So I do think that asymmetry in something like a NOR board, even though it's a very static test, it can be helpful, especially if you get data points at multiple times. If you're working in private practice, maybe you're testing this each week or maybe every other week in some form or fashion. You don't necessarily need a really fancy test, even like some kind of a prone hamstring curl machine or a single leg supine, hamstring curl. You could even do like an endurance test at like 30 degrees of knee flexion and just see how long they're able to hold their hips off the ground from side to side with a set amount of weight on their hips. Something like that could be used. If you don't have a lot of data and tech, because I knew when I was in the private industry and I would listen to podcasts and people were measuring all these things, I was like, well, gosh, yeah, it'd be real nice to have all these things and a whole sports science team, but it's just me. So I think there are ways to do it. You just may have to be a little bit more creative in how you do it. But I do think there could be some value there clinically in measuring these things. And I think it's good for them, the patient, to see progress too. If you can show somebody, hey, you started here, and even in a performance training program where they're not hurt in rehab per se, and just show them what kind of changes they're able to make, I think you get a lot of buy-in, and you give a lot of like kind of a more resilient mindset to people of like, hey man, I'm not worried about my hamstrings. Like, geez, you see how I've been able to push and grow these things? I've been working. Like, I have a lot of confidence, and really, like, when it comes to young athletes, man, just instilling some kind of like confidence in them goes an awful long way in how they play and how they carry themselves and for their life and the meaning that they get out of life and the meaning they get out of their sports. That confidence can really help.
Hey guys, quick pause and a quick shout out to this new masterclass that we just launched here at True Sports Physical Therapy. Myself and Dr. Tim Stone put together a masterclass of ACL rehab, and we call it From Table to Turf. And the reason we call it that is because it's going to teach you exactly how to get your athlete all the way from post-op day one with the nitty-gritty of regaining all of that range of motion, with the tips and the tricks that we use here at True Sports Physical Therapy that gets our athletes better, faster, and stronger. And that's early. And then how do you progress that athlete all the way onto the field with a ball in their foot or a stick in their hand or whatever their sport is, and teach them how to accelerate, how to decel, how to change direction, all the mechanics that go in there. What drills do we use to get our athletes exactly where they need to be back on the field and even better than before injury? And I want you to sign up for that class now. You can find it on our website. You can shoot us a direct message and just say, hey, send me the course. It's right now on sale, so make sure you sign up now. It is fully accredited to get you all of your continuing education hours. Sign up for the True Sports Masterclass ACL, From Table to Turf. Thanks, guys. Yeah, I think it's become so much more accessible now than, I've been doing this for 15 years, private practice for 10. It used to be you would never see a force plate. I wouldn't have known what a tin deck is. A handheld dynamometer was totally out of reach. And now that stuff's far more accessible and reasonable. So I think there is room to get good data like that. I also like the point you make of, and maybe you can touch on this next, because NOR board transpires predominantly with hip and extension, right? And so how much time do you spend testing hamstring with hip and flexion? The point is, it's easy now in private practice to do that with a tin deck. It'll cost you $100. It gives you a whole bunch of data. But can you speak on that? Because you got ranges of motion or mobility, right? Mm-hmm. You got force production by way of NOR board. Does it matter where the hip is when you're testing that knee flexion?
Yeah, let's talk about that. So the only study that I'm aware of that was trying to, and albeit they used EMG measures as well as like a force transducer at the heel, kind of similar to what you would expect like a NOR board would give you. And what they found was that when you place the foot neutral, just facing straight up and down at about 30 degrees of knee flexion, that's where you're going to get probably the most overall hamstring recruitment. Now, if you were to take the foot and rotate it out just slightly, the degree to which they rotated, I think it was only like 10 or 15 degrees of toeing out. So the heels are coming close together, toes are kind of flared out a little bit. You do preferentially bias the biceps femoris hamstring muscle group, and there's two heads to that. And that is predominantly the most common injured muscle, and even the most frequently seen way that hamstrings get hurt is at high speed running. And that typically does happen at the biceps femoris tendon. To go back to predictability and prognostic value of test, it also doesn't seem to matter how far from the ischial tuberosity down towards the knee that pain is felt. So it used to be maybe thought or hypothesized, and I hear this still now, that, oh, it's really mid belly. They'll go and follow down their hip, and it's kind of in the middle, or whoa, it's really far down in the tendon. And I've heard various reactions, like, oh man, it's in the tendon, like this is going to take forever, versus, oh good, it's mid belly. But the reality is that in the biceps femoris, because there's two heads, that tendon is massive. It goes up a little bit higher, or just at about 2/3 of the way up your posterior thigh. Wow. So when you're looking at a posterior chain injury, and you're poking in what it feels like mid belly, you could still be right on a musculotendinous junction. And that's those groups of studies that I talked about by David Opar and Christian Thorberg and Jack Hickey. When they look at both ultrasound, functional ultrasound measures, as well as MRI, almost 90%, I think they reported 90% or higher of all hamstring injuries are musculotendinous junction injuries. Very rarely is it mid-belly or muscular. And the reason for that is because there's a stiffness difference between a tendon and a muscle. So typically where you're going to see the most problematic things happen is at the junction between two materials that have different stiffness. We see this in architecture all the time, that like the metal around a bridge, the cement that holds that metal up typically is what gets weathered and worn away because of the vibrations that happen. And it's because there's different Young's modulus stiffnesses between those two things, and they don't interact very well. And so it happens that way in the tendon as well. And it just seems like that's probably more common anyway. So, I think no matter where you go, as far as high up or down, you're going to get that. And no matter where you're testing, as far as, hip extension versus hip flexion, I think you're basically, when you're testing, you're trying to get the greatest amount of mechanical advantage in the muscle, because I want to test where the athlete feels absolutely the most powerful and strong. And typically around 30 degrees knee flexion with a little bit of hip flexion. Like you'll see people in a Nordic hamstring curl, they'll try to kind of hinge at the hip a little bit and go into a little bit of anterior pelvic tilt. I'm fine with that. I typically tell people, like, all right, let's get you to a bandwidth of area where I feel like you're going to be the strongest. And then as they start pulling, they'll kind of naturally gravitate to where they're going to find the greatest amount of mechanical advantage in that movement. And I allow for that. I don't want it to be crazy strict. I want to see their pelvis roll just a little bit. I want to see the knee angle change maybe just a tiny bit until they feel like, and that's why you do maybe 3 tests to kind of normalize it, because you're going to see after that first rep, it might feel a little crampy. It might come as a surprise to them, but they'll sort of adjust and find, okay, now I'm really able to throw down some force. That's all I care about. I want you to feel the most powerful with those hamstrings, and that's typically in that kind of position that I described earlier.
Okay, that's awesome. Do you ever test them seated so that they're in hip flexion or not?
That would be more on an isokinetic dynamometer when we do like ACL testing. Now, you could do that if you have access to that pretty frequently in a clinic, which is rare. You could absolutely do that. Or if you had a seated hamstring curl machine and had like maybe, an easy way of testing that, where you could set it up where they are at a little bit of an E flexion and you're just trying to see at what point can they no longer move the weight stack, something like that may be a decent test. Or if you wanted to set up a Tyndek in that position, you could rig that up. I think, not too difficult to do that, but we just typically don't have access to that as frequently. And you'll see very strong athletes, like the guys I work with. I mean, they're putting down, over 500 Newtons on a single leg type thing on a Nord board. So it's like, all right, well, putting you in a seated position, you're going to raise yourself out of the seat or slide forward. It's very hard to get them to stay in unless you have a setup similar to an isokinetic dynamometer, which has like all the different seat belts and all the different straps and constraints. Like it's going to be hard to get a big, strong athlete to do a great seated hamstring curl type test. So I find that the Nordic type stuff usually is a little bit easier accessible. So
Yeah, no, I think that makes a lot of sense. Also, what just jumped in my mind was when you were talking about that toe out positioning and how it will bias your given hamstrings. We see this a ton coming out of ACL, where they'll have a hamstring graft, right? And when they return to sport, they're living in that toe out because they had their medial hamstring ripped out of their leg.
yeah,
So it's just kind of worth noting that. I think that study supports it. And I know there's a tremendous amount of Australian literature only because we employ an Aussie who loves quoting that. But I think there's, that's totally worthwhile. Okay, so that is, so you have some mobility, you have your force development, which again, you said asymmetries are normal, but you're going to put them in a bucket if they're two standard deviations out. And so we're creating this like cluster of predictive value, right? Is there anything else that lives in this predictive value?
I think that to date, I haven't seen anything that's incredibly convincing. I know we were going to talk a little bit about pelvic orientation, and I'm sure that that's an area of interest that a lot of people are very interested in, and I'm more than happy we'll dive into that. But as far as what I've seen, and again, going back to that study by Michael Raymond, about the predictive values and other types of, and the one by David Opar about hamstring strain injuries and those factors that may lead to it, it doesn't really seem like there's anything massively predicting. Now, what I would say, and maybe where we'll end up going, I think, and it's gained a lot of popularity, is high speed running and high velocity running. There's a great paper by Caroline Price, I believe. I think I said that right. Oh, Prince, excuse me, Caroline Prince. And they basically were looking at what exercises, if any, mimic high speed running and the types of both velocity as well as load and force that they get through the hamstrings, similar to sprinting that's not sprinting. And the truth is, like, when it came down to it, even something like a pretty intense Nordic hamstring curl, or standing in full, standing up and doing a hip extension type thing against resistance, or something like a 45-degree hyperextension with straight leg type thing, you might get more load than you do in other exercises that are similar to sprinting. But high speed running, far and away, is going to be like the number one thing for hamstring loading. So again, I think, and this is something I hammer with all my athletes in rehabilitation, maybe we can get into this, is that if you're not being exposed to high velocities, at least, every 4 or 5 days, you're doing a massive disservice to somebody coming back from a hamstring injury, because there is no amount of gym exercises or clinical testing that you can do, or asymmetry fixing that you'll do in the gym, that will replicate or fix something more than just running at high speeds and working on the technique and the postures and some of like the exposure to running. So hopefully that was helpful to dive in, and I don't know, you can take that wherever you want to go.
No, I think that's really interesting. And then, I've seen a lot of strength coaches, PTs, put emphasis on, when returning from hamstring injury, incorporating sprints very early on, and just kind of like grooving that neuromuscular pattern or connectivity. I think that speaks to the same thing you're talking about, whereas you just got to replicate it and expose the tissues to it.
Yeah.
I'd be interested to hear like how you do that. What is your algorithm to exposure? Almost like another version of exposure therapy as they're coming back. But I think that's a good place to go. So let's shoot there. So you gave me some good ideas as to how to predict, maybe prevent hamstring injury. Sounds like a lot of gray areas, but you're trying to fill as many buckets as you can there. Once they pull the hammy, walk me through the Willey evaluation and steps 1, 2, and 3.
Yeah. Well, but I will tell you that the Willey version is a stolen version from a conglomerate of everyone else in the field trying to do good things.
It's always like that. It's always like that.
Yeah. So one of the things that I think is massively important that maybe often gets overlooked is early graded exposure. And when I say early, I mean within the first 48 hours. I think typically most people post hamstring injury, there's like a 48 to 72 hour period of time where they just want to totally rest and really let things calm down. And in my opinion, I think that that is a disservice because there is a way to expose people to running related positions extremely early and even very asymptomatically that I think does wonders for the amount of apprehension and fear that happens, down the road when they get a week in. Or let's say this, somebody gets hurt and there's all this apprehension and fear. There's all of these ruminating thoughts about what this means for their athletic career, what this means that they'll be missing out on. They're going to be removed from a social situation of practicing with the team, which hurts. And there's so many bad negative thoughts that happen when people get hurt. If I can, the very next day after this happens, get a good sweat on with an athlete where they feel like I am training, they'll walk away from that with so much more hope and so much more assignment of value to the meaningful progress that they can make and the timeline of that progress versus allowing 3 days of this depression and anxiety and apprehension to build and ruminate in their mind to the point where when they come in, sure, symptoms may have decreased, maybe some of that inflammation has decreased, and we can start doing a little bit more, but they have no idea where they're actually at because they haven't had their finger on the pulse of the problem up until that point. And all that's accumulated from the time that they got hurt to the time that they're now seeing you is mostly negative.
Yeah.
And so I would like to be some kind of point man as early as possible, convincing them and basically violating their expectation that they're going to be a problem and they're going to have issues. I want to violate that early and give them hope. And so I think that just doing stuff.
I just hear like headlines, Q Willey loves violating his athletes.
Whoa.
Let's change that wording. But just tell me how you do it. Just tell me how do you, let's say, begin your exposure therapy. That's a better term.
There you go. Sure. I use violate because that is the words of JP Canario and the Lorimer Mosley and Peter O'Sullivan and a lot of their pain rehab, related papers. So yes, we'll change that term to exposure-based therapy. And I think one of the easiest ways to do it for a hamstring is changing all of your drills into more vertical-based drills. And that's where we start. So that could be just marching up and down. I don't look for the athlete to cover ground quickly. If let's say I want this drill like an A march, which is just basically standing upright, I'm picking my knees up to as high as I feel comfortable pulling that knee up. It's going to be different early on, especially for more sensitive hamstrings. Maybe they only pull their knee up 50, 60 degrees off the ground, and their other side, they're able to pull up all the way. That's fine. I don't mind. I'm just going to move with what you can, what you feel comfortable with. And I'm not concerned. Like, let's say if we're doing that A march for 10 yards, I'm not concerned with how fast you get there. I just want you to take as many steps as it takes, go through that position, because ultimately I'm trying to build resilience and a capacity. Now we go into total just GPP mode of the same way that I would prep a healthy athlete. There's going to be a period of time where drills are taking like the majority of my training time because we just need to build them up. Like I don't take a healthy athlete and just sprint their boots off the first day that we're out there. I'm going to go through some drills. I'm going to condition them into some things, into postures. And they also get a feeling of the types of language and the interaction that I get with them, the types of things that I say to them, and they have abilities to communicate and ask questions to me while they're going through these drills. I think that's important. You're developing this therapeutic relationship as they're going through something that may be scary. So I'm having them march in place, more vertical based stuff. If that's fine, maybe we'll do something like 100 yards worth of that. If that's really scary for them, and, I'll break that up, maybe like 10 sets of 10, or, maybe we'll do 150, go like 10 sets of 15 broken up into a couple different sets. And sometimes that might be as far as you get in a day. That was a lot. And anything more than that, for those a little bit more sensitive hamstrings or the little bit more fearful athlete, sometimes that's where you're going to get on the day. And that's okay. As long as I'm accumulating some great volume there, I think that's the goal. And then, you might go into something like a little bit faster marching, a little bit more skipping. Like I'll literally, like, I want you to skip and just make it more up and down. I need you to just push your, hammer and nail straight down to the ground. Don't worry about traveling downfield. Your body will do that for you. So don't worry about getting to the line. I just want you to accumulate great touches to the ground that are specific to sprinting and jumping. So it's more of like an extensive plyometric type workout. And then after that, we might do some almost high knee type things. And even early, if they're not able to get through a full range of motion with the high knees, I'm still wanting to reciprocate gait. I still want them to feel what it's like to pick one leg up and put the other leg down and put force into the ground again and again and again and again and again, so that they gain more confidence, they gain more feel that tomorrow when they come to rehab, they know what they did yesterday and they know about, right where they're at. Like I tested my waters, I found that limit, I know what I'm capable, and now I know that to that level, I don't have to be afraid. That's a big win. I just pushed the margin of what they feel like they can be exposed to. And then that next day, can I push that margin just a tiny bit more? Can we just get a little bit faster in the same drills? And ultimately, I think you could be very liberal with how much volume you do here because it's so low intensity. Their hip flexors might be on fire from picking their knees up. Their calf muscle might be just absolutely on fire, foot cramping. And that's fine, because I'm exposing you to something that I can be confident I am building this athlete up. And what an awesome thing for an athlete to walk away from a training session sore in muscles that feels like I'm actually training. Like, holy cow, what a massive overhaul of what rehab can be for them, where they're not just doing something, even though it is a little bit rudimentary and boring. It's like, man, I'm putting in work. And a lot of the guys I work with, that's all they want to feel like. They just want to, like, yeah, I'm in rehab with Q, but like we're putting in work down here, man. Like, and I want guys like dripping sweat. I want them to feel like they are working hard, that they're getting something out of it, even if we're totally working around an issue and not necessarily working through it. I want them to feel like they're just savages, and that's an easy way with a young athlete to do that.
That's awesome. If you saw them, like you gave an example, you see them in UNC, right? So you get them day one, you get them day two, you see them every freaking day. If you're seeing them in private practice, are you giving them any homework after you move them through that stuff? And what does that homework look like? And when do you actually start loading the tissue?
Yeah. So I actually made a hamstring protocol thing specifically for that, just like give athletes and it to have on their own. And so basically, like, let's say we got to 100 yards worth of marching, we got to 100 yards worth of vertical skipping, and maybe we did 100 yards of high knees. That's all we did. And that was on, maybe a Monday of the training, right? First training session or rehab session of the week. And I'm not going to see this person for another week. I may say, hey, I want you to repeat this at least X amount of times before I see you again. Probably every other day at the minimum. But, at least 4 or 5 times. I want you to repeat the same thing before I see you again. And obviously that process might go a little slower because I'm seeing them less frequently. But then when they come in, they're like, yeah, I've been doing this, and man, like, it feels so much better than the first day we did it. Like, I can do all this stuff easy. Awesome. Well, today we'll go through less volume of that. Maybe we'll do half the volume of those things. Let's get into some like 5-yard accelerations, or let's get into some 10-yard easy roll-in accelerations. I'm not looking for high speed. I'm just looking for great positions, and just give me what you got today. Let's do that. And like, then it becomes, again, same homework, right? When you go home, I want you to complete this at least 4 or 5 times, in the next week of what we did today. You're doing half the volume here. I want you to just give me a good, 10 by 10 or 100 yards, or maybe you go up to 150 yards worth of these easy roll-in 10-yard accelerations. Here's kind of, the parameters I want, and boom, they'll do that on their own, and they come back, and you just slowly progress it, from one phase to the next. I think what is your progression criteria is distance. So with even training healthy athletes, we know that in about 10 yards of all-out sprinting, you're only going to attain maybe about 70% of max velocity. So you can do an awful lot of volume there because you're only training within 70% of a 1RM theoretically. So think about this like in the weight room. If I'm moving 70% of my 1RM, you can accumulate more volume there than I could at 80s, 90s, and so on of a 1RM. So it's the same idea. Once you get out to about 15 yards, you're looking somewhere between 75 and 80%. Once you're getting to 20, you're looking between 80 and 85%. Once you get to 30 yards, now you're hitting into that 90% or higher of max V for most athletes. That will fit about 95% of athletes. Now, younger, more untrained athletes, they may hit higher velocities of their max V relative earlier in that process because they don't have as high of a ceiling. Like a kid that's not used to training very often, or hasn't really run much, sure, by 15 yards, he might be moving pretty close to what he's capable of putting down. So you may have to gauge that a little bit based on the experience of the athlete, but those are some general parameters that I look at, and I'm going to gauge the dose of what I give that person based on what percentage of velocity I feel like they're able to attain. And for the athletes, like the Division I level or people who are used to sprinting, usually at about 10 yards, you're going to see about a 70% effort. And typically I'll tell athletes, hey, on these first couple, I'm not so concerned with you really projecting out and covering ground each step. You can be a lot more vertical and a lot more prancy, kind of more boundy up and down. And then as it feels more comfortable and you feel more comfortable, yeah, then you just slowly increase that tilt to whatever degree you feel, and boom, pretty soon, and you could take measures of time if you wanted to, break out a stopwatch or timing gates or even your phone and just show them what it looks like and how many steps it takes them to get to that 10 yards or things like that. Those could be really easy, low tech ways of showing progress, demonstrable progress from week to week or month to month of like, hey, look, you're really upright and, it took you about 8 steps or 9, 10 steps to get to 10 yards. Like, look at you now. Like, look at this angle. Look how much ground you're covering. Look at these slicing, scissoring motions of the thighs. Like, you're covering ground a lot more efficiently. How does it feel to you? And subjective feedback, I think in these cases is very valuable. We made note at the very beginning of this talk that subjective patient understanding or their feel of how ready they are to return to sport is just as predictive as MRI. So it's okay to just use subjective findings of like, hey, what percentage do you feel like you need to be at to play? What percentage do you feel like you're at now? That's a fine measure. And you could even write that down. That subjective feedback is valuable. So I treat that as almost an objective measure. If an athlete's telling me they feel like they're at 75%, sweet. Yep. What are you 2 weeks from now? Oh man, I'm at 85%. Dude, like, this is awesome. We're making progress, baby. So
that's awesome. So when do you get into, and I think that's a great rubric for return to run, right? When do you start loading their posterior chain?
Yeah, so we will do that really, really soon. And when I say loading, this all again happens on a spectrum. So for instance, let's say we are, 48 to 72 hours out from initial injury, that first week. Maybe some of what we're doing is just the Askling hamstring extender. And what that is, again, from the Carl Askling studies where they did this lengthening protocol, you're laying on your back. You basically take your hands behind your knee or on your hamstring, pull your thigh into your chest as far as you feel comfortable doing. And then you're just trying to extend your knee up towards the ceiling as high as you can. Usually, I'll tell them, hey, I just want a low grade, comfortable, tolerable ache in the posterior chain, not looking for burning sensation, doesn't need to be painful, go slow, ease into it. And maybe you get, 3 sets of 8 or 3 sets of 10, 3 sets of 12. You can, dose that increasingly, linear progression with that 8, 10, 12, something simple like that. So you're doing more of an extension, just basically trying to build some tolerance into going into these ranges that are otherwise fearful. The other thing that we'll start really early is there is a test, and I hadn't heard about it before until I read it in that Raymond paper because I didn't even know it had a name. It's basically putting your leg up on like a plinth, like a table or a high, coffee table, if you will, and then just leaning forward like you would see like a typical runner, warming up and doing that little stretch. And it's called the Puranin-Orava test.
I never.
Yeah. Neither would I. But basically, I'll put them into that position and have them bend their knee just like 20 to 30 degrees so they can kind of lean over it a little bit more, similar to what maybe kind of feels like an upright running, like that lengthened stride position. And I'll just have them isometrically try to pull their heel down to meet their other foot that's on the ground, just pull into the table or pull into the box. As hard as they feel like they're capable of. And they'll grade that, just kind of ramp up. I don't need you to come in real hot, real intense. I don't need like a hard, abrupt start to it. Just sort of ramp up pressure, and they'll do that naturally. And I want you to just hold that for 5 seconds and then let off that pressure, kind of shake it out, and then go again for another 5 seconds. And maybe do 5 sets of 5 seconds with that, and then have them walk around. They could even do the extenders in between now, put them on the ground and have them extend and just sort of get it moving, like an active recovery exercise, if you will, and then go back to the isometric ones. And maybe you do 2 or 3 rounds of that in a day. And I'm not so much worried, like if you look at Alex Natera's work with isometric work and the overcoming isometric work, there is like when you look at the force values on a healthy athlete, there's going to be diminishing returns, like maybe for about 5 to 6, maybe even as high as 7 seconds in an endurance athlete. You'll see their force value kind of plateau off, and then you'll see it slowly start to come down. And they talk about that like your isometric force reserve, like how much time can you put down maximal effort. Well, we already know that when people have symptoms, they're very, very far away from what that muscle is actually capable of throwing down. So we can accumulate a lot longer durations and higher volumes, because we know, similar to the idea of the skipping and the marching and the really low load accelerations, we know that that's far away from what their body is actually capable of, because they're dealing with injury, that we're not so concerned with accumulating volume there. It should just be something that they feel like they can tolerate, that on the next 48 hours that you may see them, or 72 hours that you may see them again, they should feel like they've returned to baseline. That's even something you could just educate them on, like, hey, if you do this, just make sure that within the next 48 hours, you kind of come back to either the same or better levels. If you do, you're safe to repeat. So those are some really simple things that I might do. You can even do, if it's comfortable for them, some prone hamstring isometric type thing. So now we have both that seated type looking position as well as a prone type position, because we will be testing in that position on the NOR boards in the coming weeks or months. So like, you might as well get them a little bit strong for the test, if you will. So just put them on a prone hamstring machine, put so much weight on there that there's no possible way they're even going to move it. And just same idea, 5 seconds, give me the pull that you feel like you're capable of producing, and then let off of it. And we're just going to do that 5 times. Take a little breath, relax, like chill into this. I don't need you straining really hard. Just give me what you got today. And you could even do this with a 10 deck, right? Where you set it up and you measure the force over the course of those 5 reps. And now you have something objective to show the patient, hey, listen, the first day that we did this, you were giving me this value. We're only 7 days out. Look how much that value has changed. And that's just a massive win for them to be like, look out, I've like tripled the amount of force I can do. Like, that's awesome. So I think those are really simple, easy things that you can start doing early. If you want to, and now if you want to get into like weightlifting type stuff, like RDLs and squatting and lunging,
or even bridging.
Even bridging, sure. I think all of those things could be on the menu pretty early. It's just a matter of the load and the range of motion that you go through. And again, it really, similar to the running progressions, it's all going to come down to subjective feedback of the patient's symptoms and what they're reporting they feel comfortable doing. Like, for the most part, if somebody has a goblet squat, and they go down and maybe they get like, I don't know, a fourth of the way down or a third of the way down, like, yeah, I'm starting to feel a pull there. Awesome. Let's go like 3 seconds down, little pause at that spot, and then come out of it just as fast as you feel comfortable. And let's rip that for like, I don't know, 3 sets of 6 or 4 sets of 6. And then, cool. Next week we'll go either same weight, up in range, or higher weight, same range, and keep progressing whichever, lever you want to pull. And maybe you pull different levers at different times of the week. Maybe you have a day where like, yeah, we need to challenge some mobility here. Let's go a little lighter. Or maybe another day you're saying, we need a good stimulus here. Or maybe you do that in the same session, where one exercise you're saying, hey, I don't really mind what kind of range you get out of this, but I need to get load into this person. I need to get something heavy in a way that they can. And then I'm going to save some auxiliary or accessory exercises to improve mobility. You could do that, twice, 3 times a week, even, totally fine. It's just a matter of the dose makes the poison, how much, how often, and how aggressive are you with that. But I don't think that anything is not going to be totally off limits there, if that makes sense.
I think that makes a lot of sense. And it really speaks to the therapist needing to understand what are the goals of the given session, where was the athlete, and where are we going? Just like with any pathology, I don't think that's unique to this, but the way you structure that and that framework really screams that to me. Is the therapist has to know what you're doing. Like, don't waste an exercise, don't waste the session if you don't have a plan. So I think that's awesome. Now, are there any modalities that you love using in this instance?
I don't particularly. No, I'm a pretty, when it comes to like the actual treatment process, I think I'm a pretty hands-off therapist. When it comes to maybe the evaluation process and re-evaluation process, sure. Yeah, hands-on and making sure that you have hands and eyes on a problem. I think that lets patients know that you really care And I do think that manual therapy can extend into that realm of things where you are just providing some hands-on level of evaluation and feeling things and pushing on things. And sometimes it's even just a matter of palpation, of how sensitive is it to palpation and pushing. That can be a clinical test, and measurement of like, hey man, like, yeah, I'm pushing on the same area. It's not nearly as sensitive as it was yesterday. That's awesome. All right, sweet. Like that's cool. But as far as like dry needling, cupping, massage, ultrasound, Graston, the instrument assisted type stuff, cryotherapy, heat, you name it. I don't really provide a lot of that unless if the athlete really feels like it would be helpful, then sure, we have a whole athletic training department that loves that kind of thing, and they'd be more than happy to do that for them when they come in. But my time and my expertise, like in my opinion, I don't think that you get a doctorate degree and you don't learn a lot of critical reasoning and ability to communicate and effectively dose and program and undulate a periodization in order to just push on a hamstring. That I could teach an undergraduate student how to push and roll on a hamstring. I don't feel like that's extremely highly skilled care. And so that's just something that is my bias that I don't necessarily provide a lot of, but I have no problem with providing it if it's, something that they really feel like would help them, if that makes sense.
True Sports Physical Therapy is growing like wildfire. We have 14 locations, soon to be more. We are throughout the state of Maryland. We're in Pennsylvania, in Lebanon, in York, Pennsylvania, as well as in Delaware, in Newark and Wilmington, Delaware. Like I said, so many more practices to come, and we always need outstanding sports physical therapists. Our treatment style is unique. We are one-on-one with your athlete for 45 minutes every single session. You do the entire treatment, you do the entire evaluation, and they are in state-of-the-art facilities where you have room to run, throw, and jump and really get your athlete all the way back to on the field and better and stronger than they were. We also have outstanding salaries, comp structures, bonus abilities, 401ks, as well as a very strong continuing education offering, including in-house continuing education. And we're looking for you. Now is the time, as we are growing like crazy. Just shoot your resume over to Yoni, Y-O-N-I, at True Sports PT, or shoot us a DM and we will hit you back. We will get you in for our unique, tried and true interview process and really make a determination that this is the right place for you to grow your career and get your athletes better than ever. We can't wait to hear from you. Okay, let me ask you this. I'm totally with you in terms of the manual therapy and in terms of the passive modalities. What does the literature say? Is blood flow restriction going to enhance my athlete's ability to get back on the field? Is sting going to enhance that? Is cold plunging going to help that? Tell me what the literature proves will speed up my athlete's healing process.
Yeah, no, it's great. And you bring up blood flow restriction. I think there's been a lot of interest in that. I don't really usually group that into manual therapy. I guess it is a little bit more hands-on in some terms, but I just see that as another form of training modality. Like it can be a great way of just providing a good volume of training to a hamstring or other, areas like, if squatting is really challenging, all right, well, are there some other ways I could challenge a quad? Is there some other ways I could challenge the hip? Sure. We could do some BFR related stuff and really get great strength and hypertrophy gains from doing, temporary BFR. It's not, a solve all that we're going to, here on forever do in all of your training, but like for the time being, while things are limited, 100%, that's a great modality. And I think as far as the literature goes, very mixed, very, very mixed when it comes to return to sport. Again, if we don't even have the clinical ability to diagnose how quickly some people will come back, regardless of treatment protocol, boy, you're taking major mental leaps to say that those who receive manual therapy have greater return to sport. And you may see that, but the studies that report that, and this is the problem with most manual therapy studies, it's always an A+B type intervention where, one group gets exercise and nothing, or exercise and intervention, and the other group gets exercise and hands-on. Well, of course, the group that's getting hands-on and all the extra care and probably, and the studies never report this, but look at anybody who uses manual therapy, they usually have some narratives around it. And there's also a socio-cultural expectation of what manual therapy does from those who are not educated and ignorant to the science behind manual therapy, that there's an expectation bias that's going to happen of when you receive manual therapy. I don't think that that means that manual therapy is useless. I'm certainly not trying to say that. Is there a place for it? 100%. And if somebody feels like it's going to help them and you have all of the resources to do so, absolutely. Where I think I have the biggest problem is the narratives that come with manual therapy when it's saying, oh yeah, I'm releasing this, I'm changing this fascia, I'm lengthening this, I'm releasing scar tissue, I'm changing trigger points. None of that is true. We know that is very reliable research that none of that actually occurs. And then the other problem that I have with typical physical therapy clinicians, and even it's not really their fault, this happens in curriculum in school, is that our therapeutic exercise, and programming, our ability to periodize a great training program is so poor in the rehabilitation community, where it's like, if I ask somebody, I want you to put together a high performance speed program, oh my God, they would have no idea how to do that.
I hope you're changing that, Q. I hope UNC is different. I don't know if you're an adjunct professor there, but I think it's such a hole in our education. It's so unfortunate.
Yeah, absolutely. I mean, the amount of young clinicians that even know what I'm talking about when I say undulating periodization and the different types: daily undulating periodization, weekly undulating periodization, monthly undulating periodization, linear block periodization, like these things go over their head, and usually, like, and it's not bad. Like, don't get me wrong. It's programming something like 3x6, 3x8, 3x10, 3x12. Like, you're probably going to be fine. I tell this to students all the time when they ask me, like, look at all the amazing athletes that did absolutely bogus programs all through high school, and they're freaks anyways. They do bogus bodybuilding training, and they still get wildly faster. So, like, the range of possibility of doing, maybe not the most ideal programming, you could still benefit from. But when it comes to a rehabilitation standpoint, where the dose does make the poison, and you do need to know how to progress movement, how to progress the times, the intensities that you're really trying to hammer within maybe a tighter variation or a tighter range when it matters a little bit more, our education does a massive disservice, where we have such an interest in the fix-its and the reducing pain and looking like a wizard, to the patient in the test retest, like, watch this, like, ooh, you were tight, and then I pressed on this thing and I did this manual therapy, and then, ooh, look how much further you can get in my clinic today, and now I'm the hero. Like, everybody wants to feel that way, but no one wants to play this long game of, like, yeah, it took us a month to get here, and it was an absolute grind. And we accomplished so much together, and had our ups and downs. No one wants that. That doesn't sound sexy. Are you kidding me? I want the magic, baby. So, yeah.
But that's why I started this podcast. So you could deliver that last soliloquy, because it's so important. And I think it's missing in the profession. I just think we fall in love with either making ourselves the hero or this just antiquated interventions. And I think you did an awesome job dispelling some of those. Q, I could talk to you forever. There's so many questions that I didn't get to, but I hope we didn't lose half our listenership already. But I'm going to bring you back. Q, I'm going to bring you back. You've been an awesome guest. Can you please tell everyone how they find you? Because I'm sure they're already following you, but if they're not, how do they find you? And how do we get some of your programming? What's the best way to get more Q in our life?
For sure. Yeah. You can follow me on Instagram. Is probably the best place to follow, reach out to me. I'm pretty active there. I try to post a little something every day. So it's coach_Q_physio. If you just type Coach Q Physio, you'll find me. And I have a link in bio. I haven't upgraded to any like paid advertising where you can just click on all the fancy stuff and access my website. But yeah, just click on the link tree. When you pull that up, there is a hamstring protocol that I've written that covers a lot of what we've talked about. And this was a culmination of works between David Opar, Christian Thorberg, Jack Hickey, Carl Askling, Derek Hansen in the sprint world. People know that guy. And it's a culmination of all of that, as well as the Aspetar research group that put together a free hamstring protocol online, which you can look up the tests. It's just that the problem with that free protocol is that there's not as much programming of what to do with the information. It's just telling you what phase you're in, but there's not as much of like, okay, yeah, but now what do I do with it? And so I tried to put together something where it was like, here's not only a criteria-based protocol of testing, but here's what you do at each of these stages and what maybe the athlete will be cleared for just after working with lots of athletes. So you can find that on that link tree. If you're looking for programs, you can find them on the link tree as well. There should be some new programs coming up on the Barbell Medicine app as well that I'm putting together for the hybrid athletes and field and court team sport athletes as well. So there you go.
Dude, that's awesome. You have made good on my intro on that. There are a lot of great people at UNC.
Yeah.
It's really awesome. It seems like a great place. Let's close with this. The best UNC athlete you've ever come across.
The best UNC athlete I've ever come across. Honestly, I used to work with men's basketball, and one of my favorite athletes I think I worked with was Cam Johnson. And we have another athlete right now with football. His name's JJ Jones. Both of these athletes had femoral acetabular impingement type symptoms. They had surgery, repeated surgeries.
Wow.
And Cam Johnson, I remember him walking into the weight room those first couple of times after surgery, and the amount of violence that man could bring into his rehabilitation, and the way that he chased his goals in spite of his injury was absurd. He trained so hard to have an amazing season that following season, and then do well in his rookie years in the NBA. So just some absolute beast athletes coming through after surgery.
Oh, I love to hear it. Okay, Q, a serious pleasure, man. We will be in regular touch, and I'm looking forward to continuing.
Yeah, awesome, man. Thank you for having me.
Absolutely.